Good morning, everybody. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about cervical cancer. So what we wanted to discuss today, the etiology, the epidemiology, and the pathogenesis of cervical cancer, the risk factors, the diagnosis, staging, screening, and how to prevent, and the management and prognosis. Let us start with the etiology and the included factor which is very important, which is human papillomavirus type 16 and 18, as you see in the picture. We know that human papillomavirus include many types, 103 types or more, 20 of them included in many cancers. While as regard the cancer, cervical carcinoma, we are talking about the most important type of human papillomavirus, which is 16 and 18. The young girls infected with human papillomavirus, especially with early sexual activity before the age of 25, and usually spontaneous resolution happen without any problem. But sometimes there is progressing to CIN 1, 2, and 3. The risk factors for human papillomavirus and cervical cancer include age at first intercourse, multiple sexual partner, presence of herpes simplex, HIV, co-infection with other genital infection, and oral contraceptive use, especially for a long period, more than 5 years. So, this is the risk factors or some of the risk factors, including also smoking. Human papillomavirus is transmitted by skin-to-skin contact, including during sexual intercourse and the hand-to-genital organ contact. Every year, approximately 300,000 women die due to cervical cancer. The highest incidence is among women between the age 40 to 49 years. On a global level, the highest rate among the black women, and in total 84% of cases are found in low resources countries. This reflects the lack of screening, shortage of the effective treatment of the precancerous lesions, as well as exposure to some risk factors like human papillomavirus, chlamydia infection, or other sexually transmitted disease, smoking, and oral contraceptive combined pills for long duration. So this is the epidemiology. Also, rates of cervical cancer in United States are higher in southern region. And as we mentioned, as regards the ethnicity, black women and Hispanic women are at more risk for cervical carcinoma. Human papillomavirus infection is a precursor of the development of cervical cancer. This is already proved. Early detection of the precancerous lesion with Pap test is the primary mechanism for cancer prevention. What about the pathogenesis? Human papillomavirus detected in 99.7% of squamous cell carcinoma and adenocarcinoma, which constitute the majority of cervical carcinoma. As we mentioned before, type 16 and 18 involved in 70% of cervical cancer cases. Most sexually active adults will be exposed to human papillomavirus, and more than 50% of adults 20 to 24 years of age are currently infected. However, the immune system cleared the virus within 6 months in 50% of women with the infection, and within 2 years in up to 90% of women. Okay, let us understand this point because it is very important. Where is the site of infection and where is the commonest site for cervical carcinoma? The commonest site is the transformation zone because it is the site of metaplastic epithelium. So what is the transformation zone? Please look to this picture down here. This is before puberty. This is the columnar epithelium of the endocervical canal, and this is the ectocervix with squamous epithelium, and this is the squamocolumnar junction. Okay, after puberty, little eversion occurred of the ectocervix, exposing the columnar epithelium to the vaginal environment. Then metaplasia happened in this part of the cervix, so columnar epithelium changed to be squamous epithelium. That's why we have another squamocolumnar junction now, the second one here, and the previous one was here, the first one here. So the transformation zone is the area between primary squamocolumnar junction in this area and the secondary squamocolumnar junction in this area. So this is called, this area, this blue line is the transformation zone. This is the commonest site for malignancy and infection with human papilloma virus. Okay? Infection with the human papilloma virus will lead to CIN1, which may resolve spontaneously or progress to CIN2, then CIN3, then go to be invasive cancer. If not discovered at this stage, CIN2 or CIN3, and managed very well, the patient will have invasive cancer. That's why the program for screening for CIN running in developed countries, preventing many cases of invasive cervical carcinoma. Okay? What are the commonest histopathologic types? Squamous cell carcinoma constitutes 71%, which may be keratinizing or non-keratinizing or verrucous. Adenocarcinoma constitutes 25%, may be clear cell or endometrioid. The third main type, adenocarcinoma, constitutes 25%, and the squamous cell constitutes 71%. So the commonest is the squamous cell carcinoma. Adenosquamous carcinoma constitutes 4% and may be adenoid cystic or small cell or undifferentiated. There are other rare histopathologic variants like melanoma, malignant melanoma, and neuroendocrinological malignant tumors. There are many things specific for adenocarcinoma. I wanted to tell you that the incidence of adenocarcinoma has increased by 35% over the past 35 years. Although risk factors, diagnosing and the staging and the treatment of adenocarcinoma are generally the same for squamous cell carcinoma, there are some additional considerations. What is these considerations? Ovarian metastases are more common with adenocarcinoma, and thus oophorectomy is recommended in early stage disease. And the larger adenocarcinoma greater than 2 cm are more likely to involve lymph nodes and have a higher recurrence rate compared with squamous cell carcinoma of the same size. What are the risk factors for cervical carcinoma? We mentioned on the top, human papilloma virus type 16 and 18, smoking, also genetic factor, combined oral contraceptive pills when taken more than 5 years, or more, the mechanism appears to be hormonal rather than behavioral. What does it mean? The effect due to sex steroid effect on oncogene expression, and the risk appears to decline after cessation of oral contraceptive. So it is related to the effect on oncogene expression. However, CIN is not currently a contraindication to oral contraceptive use. What are the other risk factors? Black or Hispanic race, history of sexually transmitted infection like chlamydia, like HIV, immune suppression, low socioeconomic status, and the family history. What about the diagnosis? Many cases are asymptomatic and diagnosed only during screening program in developed countries. When they are doing BAP test for the lady in the program or in the screening program, they can find the abnormal cells and they can diagnose CIN 1, 2, and 3. Also, they can examine to confirm using colposcopy, and you can see here different lesions in the cervix, in the normal cervix, and this is a cytowide area, and this is suspicious cervix, and this is invasive cancer. You should ask the woman about the age of the first sexual activity, any history of previous sexually transmitted disease, any history of postcoital bleeding, because it is very important. You should ask about the postcoital bleeding or any contact bleeding, the number of lifetime partners, because the risk increase with multiple partners, previous history of human papillomavirus infection, or previous history of vaccinated for human papillomavirus, history of human immune deficiency virus, history of use of tobacco, and the woman should be asked about the menstrual pattern and any abnormal bleeding or discharge, any irritations, or non-cervical lesion before. In advanced lesion with the infiltration of the parametrium, ureteric obstruction may happen and the patient may complain of renal colic and symptoms and signs of renal failure. And the cause of death in cervical carcinoma is renal failure on the top. Also, infiltration of the bladder will cause bladder symptoms, or the bowel will cause bowel symptoms. Also, back or pelvic pain may occur. What about the physical examination? General, abdominal, and the local examination. What is very important is the pelvic examination, and you should examine the external genitalia and the internal genitalia, and you should assess any presence of mass in the uterus or adnexy. Also, mass in the cervix, of course, and any contact bleeding. And if there is mass of the cervix, maybe ulcerative or cauliflower mass, or there may be indurated cervix or barrel-shaped cervix in endocervical carcinoma. Also, we should do BR examination under anesthesia to examine the parametrial area for any parametrial infiltration and if it is reaching the lateral pelvic wall or not, because it will affect the staging of the cervical carcinoma. And of course, during examination under anesthesia, you can take biopsy from the visible lesion in the cervix. This is a case of cervical carcinoma also. If you see a lesion like that, like cauliflower mass or ulcerative, you should take a biopsy and send for histopathological evaluation. Imaging play an important role also, like MRI, as in this picture. This is the cervical mass, cervical carcinoma. Also CT can be used, and the PET scan for detecting the metastases in different areas in the pelvis and the abdomen and chest and lymph nodes and the lymphovascular space invasion. And you should remember that cervical carcinoma is different than ovarian and endometrial carcinoma, being staging. The staging is clinical and radiological, not operative staging. If you remember, in ovarian and endometrial cancer, we said that the staging is laparotomy or laparoscopy staging, while in cervical carcinoma, went on the clinical examination and radiological investigations, imaging varieties. So what is the differential diagnosis? Mass arising from the cervix, maybe polyp, maybe fibroid, maybe genital warts, maybe infection, like sexually transmitted infection, endometriosis, cervical ectopic pregnancy. All these are differential diagnoses for cervical carcinoma. And the biopsy can diagnose very well and exclude the other causes of cervical mass. What about the spread? Lymphatic spread has a major role in cervical carcinoma, and we have two big groups, primary group and secondary group. The primary group, look to the picture please, including the paracervical, parametrial, this is the parametrial, this is the paracervical or paratubal, also the obturator, lymph nodes, hypogastric nodes surrounding the obturator vessel, hypogastric nodes along the hypogastric vein near its junction with external iliac, then sacral nodes. This is the sacral node. The secondary group include the common iliac and the para-aortic lymph nodes, and also inguinal lymph node, superficial and deep, femoral nodes. What about direct spread? Look to the picture. Cervical carcinoma can extend up to the uterus, to the endometrium of the uterus, and down to the vagina, and laterally to the parametrium, and infiltrate the ureter and can cause obstruction and hydroureter and hydronephrosis and renal failure up to reaching the lateral pelvic wall, and also can extend anteriorly to the bladder and posteriorly through the uterosacral ligament to the rectum. Also, another method of spread is blood spread to distant organs like lung and bones, and to the ovary and the brain. Also, implantation may be another method of spread to the vaginal fornices, vulva, and the abdominal wound during surgery. This is the updated staging by FIGO 2018 with some difference than the older one. Please look to this picture. We can explain more here. We have 4 stages. This is stage 1. The lesion localized to the cervix, as you see, not extending beyond the cervix, but it can be divided into 1A and 1B. 1A is called the microscopic lesion, and it cannot be detected by MRI but detected by biopsy. 1A is divided into 2 categories, A1 and A2. A1 less than 3 mm stromal invasion, while A2 3 to 4 mm stromal invasion. B, according the side of the mass, we can divide them into 3 categories, B1, 2, and 3. Less than or equal to 2 centimeters is B1, from 2 to 4 centimeter B2, as in this picture. This is B1, this is B2. More than 4 centimeter, it is B3. Let us go to stage 2. In stage 2, the spread to the vagina and the parametrium start. So I have 2A extending to the vagina, to the upper 2/3 of the vagina, and they can be divided into two categories: 2A1 less than 4 centimeter or equal to 4 centimeter, A2 more than 4 centimeter. Okay. What about stage 2B? We said there is parametrial infiltration but not reaching the lateral pelvic wall. Okay, this is stage 2. Let us go to the stage 3. Stage 3, we continue what happened in stage 2. Stage 3A, the tumor extends to the lower third of the vagina, while 3B extends to the parametrium reaching the lateral pelvic wall, while stage 3C is extending to pelvic and the para-aortic lymph nodes. And I can divide them into C1 if there is the extension to the pelvic lymph nodes, or C2 if extending to the para-aortic lymph node. Stage 4, invasion of the bladder mucosa here must be invasion to the mucosa itself. Okay, or rectal mucosa. This is stage 4A. Stage 4B, distant organ metastasis. What about cervical screening? Cervical screening is primary to prevent cervical cancer and secondary to detect early stages of invasive cancer by offering equal opportunities for women to get screened. As you see in the picture, this is one of the methods for screening using a cytobrush, taking smear from the cervical smear and send for cytological analysis. This is what's called the PAP test or Baba-Nicolstein test. Okay, and the other picture here, colposcopic examination. If suspicious CIN, we can examine with colposcopy and qualify if there is non-invasive lesion or invasive lesion, and also can take a biopsy. Okay. Also, I can do human papilloma virus test. This is another screening test, human papilloma virus test. This is the aceto-white, the visual inspection with acetic acid, what is called the VIA test. And this is the aceto-white areas in the transformation zone, denoting that there is lesion here, maybe CIN. Okay? Okay. Then you can continue to take a biopsy to confirm or do colposcopic examination, and you can manage immediately in one session. VIA test is very cheap. I use acetic acid, the fresh one, 4% concentration, available everywhere, so it is very cheap and not costly at all. And it can be used for low resources countries easily, and everybody can be trained on doing the VIA test. I gave you here one of the screening program in Sweden country, screening every third year for women ages between 23 to 29 with cytology and cytology and PAP test, and from 30 to 49 years age with primary human papillomavirus test. At the age of 41, we do both human papilloma test and the cytology. Then, after that, primary human papilloma testing is also used for the age group between 50 to 64, who are screened every 7th year. Of course, this screening program differs between country and another country, but the same idea. Okay? How to protect from human papillomavirus infection, and thus you can prevent cervical carcinoma by using human papillomavirus vaccine. And there is available two vaccine, Gardasil and the Cervarix. What is the difference between them? This is a Gardasil. Protect against 4 types of human papillomavirus. The most risky one is 16 and 18 because of they are included in cervical carcinoma, and also another types 6 and 11 which included in genital warts. So this vaccine gives protection against 4 types, while Cervarix gives protection against only 2 types, 16 and 18. Both of them given in 2 doses, half milli intramuscular in the deltoid region. In the school age girls, Cervarix is given at the age of 9, Gardasil is given at the age of 12, and the second dose is given after 6 to 24 months. While in Cervarix, the second dose is given after 5 or 13 months. What is the management of precancerous lesion? Many of the cases managed conservatively. Those women younger than 25 years, the majority of abnormal findings in women younger than 25 are low-risk cervical dysplasia and will resolve spontaneously with their immunity, as we said before. Colposcopy evaluate persistent abnormal cytology or lesions suspected to be greater than low risk. These are managed according to the findings. Low-risk lesions may be watched and re-evaluated more frequently, and the high-risk lesions are treated based on size, location, and the staging. What are the different lines of treatment? Cryotherapy or excision, conization, laser or loop electrosurgical excision, what's called LEAP, as in the picture here. This is LEAP, excision of the transformation zone, this area of the cervix and the area around. If you diagnosed invasive cancer, you should do staging and go to further treatment. So, the precancerous lesion at the level of cervical CIN, cervical intraepithelial neoplasia, CIN 1, 2, and 3. What is the management of cervical cancer? Management of cervical cancer may be surgical, laparoscopic, or robotic, or laparotomy, or radiotherapy, brachytherapy, or teletherapy, or chemotherapy. But the management strategy will depend on the stage, lymph node involvement, risk factors of recurrence, patient comorbidities. Please look to this table because it is very important. This is for early stage tumor which start from less than 1 B2 stage and stage 2 A1. Okay, Okay, this is early stage 2. Take care we didn't put 1B3 and jump it to stage 2A1. Okay? Because we put 1B3 in the more advanced stage. 1B3, if you remember, we said the size is more than 4 centimeters. So the metastasis is higher, so it is considered the advanced stage. Okay? What is the advanced stage? 1B3, 2A2, and 4B, up to 4B. From 2A2 up to 4B. Okay? So, more advanced stage, 1B3, and from stage 2A2 up to 4B. Those with advanced stage, the main line of treatment is chemoradiotherapy. Those with early stage tumor, management in the following routes. For the stage 1, A1, and the A2, conization or simple hysterectomy is recommended, and the presence of lymphovascular space invasion, a pelvic lymphadenectomy or sentinel lymph node dissection is performed. What about stage 1B1 and 1B2? And stage 2A1? Radical hysterectomy with systemic pelvic lymphadenectomy is the treatment of choice. What about if I wanna to do fertility sparing surgery? Because the patient is young and they need to be pregnant. I can do trachelectomy, which is performed for tumor equal to or less than 2 centimeters, except if high risk histology is present. Okay? I can do the surgical operation by robotic, laparoscopic, or laparotomy. Of course, laparoscopic or robotic is minimal invasive approach, and many prefer this approach because of many advantages. This is types of hysterectomy. There is different classification for the types of hysterectomy, but this is one of them. Simple or extrafacial hysterectomy, we remove the uterus and the cervix, but without the parametria or vagina, and it is called the class 1. Modified radical hysterectomy, we remove the uterus and the cervix and the parametria and the upper 1/4 of the vagina, and we call it class 2. Radical hysterectomy, we remove the uterus and the cervix and the additional parametria and the upper 1/2 of the vagina, and we call it class 3. The upper 3/4 of the vagina, if removed, we call it class 4. Additional resection of a portion of the bladder, we call it class 5. So, radical hysterectomy could be one of these 3 varieties. What about the minimal invasive surgery? The first laparoscopic radical hysterectomy was performed in early 1990s. Subsequent studies with mainly morbidity outcomes were promising compared with open surgical approach. FDA approved robot-assisted laparoscopy for gynecologic surgical treatment in 2005. And the year after, the first case report of robot-assisted laparoscopic radical hysterectomy was published. Compared with laparoscopic technique, which is considered highly challenging, the robotic surgery provided improved surgical conditions, especially in deep and narrow pelvic cavity with improved precision by robotics. Moreover, in comparison with the laparotomy, the robotic technique offers several advantages, which have been present in numerous publications, such as decreased blood loss, relatively acceptable operation time, and shorter length of stay. But the problem with robotic surgery, although it carries many advantages, being expensive and need a well-equipped hospital. So you can find it in the developed countries, and it is really carry many advantages. At 2016 Cochrane review of 401 women with early disease and risk factors for recurrence found that after surgery, adjuvant platinum-based chemoradiation significantly reduced the mortality compared with radiation alone. Women who are not surgical candidates may be treated with primary radiation therapy or chemoradiation. As in the picture here, you can see here at the time of diagnosis with MRI, the cervical lesion, and here after brachytherapy, as you see here in this picture. This is at the time of diagnosis, and this is at the time of the brachytherapy. What about the chemoradiation? Locally advanced cervical cancer is often treated with primary chemoradiation. Currently, treatment is based on combination therapy with platinum-based regimen. Radiation involves external beam radiotherapy and high-dose intracavitary brachytherapy. As you see here, this is the brachytherapy, the intracavitary brachytherapy. Post-treatment hysterectomy is not associated with increased survival rate, and therefore is generally not recommended. However, hysterectomy may be performed in patients who have large bulk tumors or high post-treatment tumor volume. What about recurrence? Recurrence of cervical cancer occurs locoregionally or as a metastatic disease, usually within 3 years of treatment. Therefore, initial close follow-up is very important with gynecologists, oncologists for pelvic examination at regular 3 to 6 months interval is recommended to the first 2 to 5 years following treatment. Women with local recurrence may present with the following symptoms: vaginal discharge, bleeding, per vagina, dyspareunia, or pelvic pain. Also, metastatic symptoms may be vague or related to the affected site, like bone pain if there is metastasis to the bone. On physical examination, physician may palpate or visualize a mass at the vaginal cuff. Imaging is not recommended unless otherwise indicated based on symptoms or physical examination findings. So we can utilize the imaging properly according to the need. What is the management of recurrent disease? The management includes medical or surgical option. For local recurrent, surgical resection with hysterectomy or pelvic excision is an option. What is the excision? Is an ultra-radical surgical procedure that involves in-block removal of female reproductive organs, the lower urinary tract, and the portion of the rectus sigmoid. Is generally used for women who have had previous unsuccessful radiation treatment with or without hysterectomy, and it has 50% cure rate. However, the procedure has a 3 to 5% mortality rate. 50% of the patients have major complication. Of course, it is very aggressive surgery, and we will do colostomy and Of course, we will do diversion also, or formation of artificial bladder, or diversion of the urine to another way. So it is very aggressive surgery, really, and carry many morbidities. Management of advanced metastatic disease. With advanced metastatic disease should be treated with chemotherapy and radiotherapy, if not given before. Avastin bevacizumab is an antivascular endothelial growth factor, monoclonal antibody that inhibit tumor angiogenesis. Adding bevacizumab to combination chemotherapy was associated with a 23% improvement in overall survival. What is the complication of cervical carcinoma? We said before, because of infiltration of the parametrium and infiltration of the ureter, renal failure is the first cause of death. Hydronephrosis, of course, pain, lymphedema, bleeding disorder, and fistula. Rare sequelae may include orbital index and blindness. What about pregnancy and cervical carcinoma? We can do colposcopy without endocervical curettage at gestational age of 20 weeks, if indicated, based on the American Society for Colposcopy and Cervical Pathology guideline for managing an abnormal Pap test result. If we found stage 1A1, we can do conization, and of course, obstetrician should be consulted about this conization for risk of preterm labor or any obstetric complication during pregnancy. In a woman with more advanced disease, management should be individualized based on stage, gestational age, and desire for continuation of the pregnancy. Also, we should know that the imaging, like CT scan, for example, and also the contrast media, all of them teratogenic to the fetus. Prognosis for cervical carcinoma depend on stage, tumor volume, depth of cervical stromal invasion, and the lymphovascular space invasion, and the metastasis. Disease stage and the lymph node status are the two most prognostic factors. Women with stage 1A disease have 93% 5-year survival rate, but lymphovascular invasion reduces this by approximately 50%. The higher stage at presentation decreases survival and increases the chance of recurrence. The estimated effectiveness of human papillomavirus vaccination is 90%. Inconsistent screening is an independent risk factor for the late diagnosis of cervical cancer. Thank you. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.